Hey everyone, and welcome to today's Explainer. We are jumping right into a totally fascinating breakdown of insulin complications. Look, insulin is absolutely a miracle of modern medicine, right? But it demands immense, almost perfect precision. And when that precision slips even a little bit, our bodies react in some incredibly complex ways. So today, we're going to put on our medical detective hats. We'll start with the immediate dangerous reactions to insulin errors, then look at some physical side effects, and finally, we are going to unravel one of the most perplexing mysteries in all of endocrinology, the morning paradox. Let's decode the science together.
Okay, here's our roadmap for today. First, common insulin complications. 2. Managing hypoglycemia severity. 3. Skin reactions and allergies. 4. The dawn phenomenon. 5. The Somogyi phenomenon, and 6, we'll wrap up by comparing dawn versus Somogyi side by side.
All right, let's jump right into Section 1, Common Insulin Complications, when treatment goes awry.
So, you know that balancing insulin and glucose is basically a physiological tightrope walk. And when treatment goes awry, the most common thing we see is hypoglycemia. That's when blood glucose falls below 70 milligrams per deciliter. But look at the causes here for a second. It's almost never just a mathematical error in drawing up the dose. No, it's usually driven by behavior. It's the patient who dutifully takes their morning shot, but then, they get distracted and completely skip breakfast. Or maybe they take the insulin but just don't eat enough carbs to actually match the dose. The insulin is doing exactly what it's supposed to do. It's clearing glucose out of the blood. But without new glucose coming in from a meal, well, the bottom completely drops out.
Which brings us to Section 2, Managing Hypoglycemia Severity. A tiered approach.
Because this bottoming out effect can range from, say, a mild annoyance to a literal life-threatening emergency, we absolutely cannot treat all hypoglycemia the same way. Check out how the symptoms escalate as these numbers drop. In the mild stage, dropping below 60, the body is sounding the alarm. We see diaphoresis, which is sweating, along with a racing heart and jitteriness. The fix here is super simple, 10 to 15 grams of oral carbs. But if they tank below 40 into the moderate zone, the brain is literally starving. You're going to see confusion, altered consciousness. At this point, we need to double those oral carbs to 20 or 30 grams. Now, if they crash into the severe stage, dipping below 20, guys, this is a red alert emergency. Seizures, unconsciousness, even a coma. And obviously, you cannot force oral carbs into an unconscious patient, right? So the protocol aggressively shifts to 25 grams of IV carbohydrates. In a clinical setting, this usually means pushing 100 milliliters of 25% dextrose or 50 milliliters of 50% dextrose. And hey, if you don't have IV access, you are immediately reaching for glucagon, given IM or subcutaneously. It has to be a highly precise, tiered response to stop a cascading emergency.
Moving on to Section 3, Skin Reactions and Allergies. Dermatological side effects.
Think about it. Injecting a hormone into your subcutaneous tissue day after day, year after year, it inevitably takes a physical toll. Historically, animal-derived insulin was the go-to. But because it's just slightly structurally different from the insulin our own bodies make, it frequently triggered localized allergic reactions. We're talking immediate redness, swelling, and just severe uncomfortable itching right at the injection site. The clinical solution for this? It's beautifully simple. You just switch the patient to human insulin, and it almost entirely resolves those allergies.
But allergies definitely aren't the only skin issue. We also see these structural deformations, clinically known as lipodystrophy. Let's just break that word down for a second. Lipo refers to lipid or fat tissue, and dystrophy means a disturbance or a difficulty. So we are literally looking at a localized disturbance in the fat tissue exactly where the needle goes in. And the wild thing is, as you can see, this actually manifests in two completely distinct, basically opposite ways. Let's compare these two. First up, we have lipoatrophy. Now, atrophy means wasting away. This actually creates literal dimple-like indentations or craters in the skin. And just like those allergic reactions we just talked about, lipoatrophy is heavily associated with using animal insulin. So the fix is, again, switching them over to human insulin. Conversely, though, we have lipohypertrophy. Hyper means excess. So instead of a dimple, the patient develops these elevated rubbery bumps. Why? Because the patient just keeps injecting their insulin into the exact same spot day in, day out, usually right around the belly button. The insulin is actually stimulating local fat growth there. The clinical fix for this one is 100% behavioral. You've got to instruct the patient to systematically rotate their injection sites. Today the abdomen, tomorrow the thigh, the next day the arm. You got to rotate the site, not just the syringe.
Okay, so here's where things get really wild. This is the physiological mystery I promised you at the start. Picture this. A patient religiously takes their prescribed evening dose of insulin. They go to sleep, they wake up, they haven't eaten a single bite of breakfast yet, they check their blood sugar, and it is inexplicably dangerously high. How on earth is this possible? The insulin was taken, zero food was consumed, yet the glucose is spiking. What exactly is happening to them in the dark of the night?
Let's figure it out in Section 4, the dawn phenomenon, the danger of playing doctor. To solve this morning mystery, we really have to look at two distinct phenomena, and we'll start with the dawn phenomenon. This usually begins with a very common human error, the patient deciding to play doctor. Let's trace this step by step. Let's say their physician prescribed 30 units of evening NPH insulin. But the patient gets anxious. They're thinking, man, if I take 30 now, next year I'll need 40, then 50. I don't want to get dependent on this stuff. So secretly, without telling anyone, they drop their own dose down to 20 units. Step 2, midnight hits. The insulin reaches its peak effectiveness. But because they lowered the dose, it just doesn't have the necessary strength. Now step 3, as the sun gets ready to rise, the human body naturally releases a daily surge of steroids and growth hormones just to wake us up. And these hormones naturally raise blood sugar. Finally, step 4, because that insulin dose was artificially lowered by the patient, there just isn't enough active insulin left in their system to neutralize this natural morning hormone spike. And the result? They wake up with high blood sugar.
So how do we remember this and, more importantly, treat it? The source instructor provides an absolutely brilliant mnemonic here, the 3 Ds. When you see the dawn phenomenon, remember that the patient's insulin went down because they decreased it. Therefore, the clinical treatment is the Hindi phrase dete raho, which translates to keep giving. You literally need to increase that evening dose back up to where it should be. Dawn means it went down, so keep giving. It's simple, it's memorable, and it's highly effective.
Now for the other side of the coin, Section 5, the Somoji phenomenon, the rebound effect.
So let's pivot to the second mechanism behind morning hyperglycemia, and honestly, this one is far more dangerous. If the dawn phenomenon is caused by taking too little insulin, the Somoji phenomenon is triggered by the exact opposite behaviors. Point 1, taking an excess amount of insulin. Imagine a patient who normally takes 20 units, but they're going to a massive wedding feast the next day. They think to themselves, hey, I'll just take 40 units tonight so I'm totally prepared for tomorrow and don't even have to bring my vials. Right? Or, point 2, they take their normal 20 units, but they get busy and just completely skip their evening meal. In both of these scenarios, what they've done is introduce a massive overabundance of insulin relative to the glucose in their system right before they go to sleep.
Let's actually narrate this midnight battle for survival, because it's intense. At bedtime, the excess insulin is administered, or that meal is skipped. Fast forward to between 2 a.m. and 3 a.m. The insulin hits its absolute peak, but there is no food in the stomach to balance it. The patient is fast asleep, entirely unaware that their blood sugar is plunging into severe, life-threatening hypoglycemia. They are literally bordering on a coma. But the human body is incredibly resilient. To save its own life, the body panics. In those pre-dawn hours, it floods the system with emergency rescue hormones, just massive amounts of steroids and growth hormone, desperately dumping whatever stored glucose it has into the blood just to prevent brain death. Now, this massive overcompensation does save the patient's life. But when they finally wake up in the early morning, that desperate hormone dump has caused a massive rebound hyperglycemia. To treat this one, we turn to our second brilliant mnemonic from the source, the 3 S's. Samagaji is triggered by taking sarvadic, which is a Hindi term for excess. Basically, they took way too much. Therefore, the treatment is to actually return that dose to a suitable, much lower level. Samagaji means sarvadic, or excess, so return to suitability.
Bringing it all together now in Section 6, Dawn versus Somoji, solving the morning mystery.
Okay, so you have a patient sitting right in front of you with inexplicably high morning blood sugar. How do you know, is it dawn or is it Somoji? Placing these two confusing phenomena side by side reveals the ultimate paradox of diabetes management. Look at the morning result for both. They are exactly the same. Both present with hyperglycemia, but look at the initial errors in the treatments. They are total opposites. The dawn phenomenon happens because they decrease their dose, so to fix the morning high, you must increase their evening insulin. But the Somoji phenomenon happens because they took an excess dose. Therefore, to fix that morning high, you actually have to decrease their evening insulin. Think about how crazy that is. If you mix these up, like if you increase the dose of a Somoji patient just because you see a high morning blood sugar, you will push their midnight hypoglycemia even lower the next night, potentially killing them. So what's the key to diagnosing which is which? You have to have the patient set an alarm and test their blood sugar at 3 a.m. That's the secret. If it's normal or high at 3 a.m., it's dawn. If it's dangerously low at 3 a.m., it's soma G.
And guys, that brings us to the ultimate question you really must ask yourself as a clinician or a focused learner. When reviewing a patient's morning hyperglycemia, are you simply looking at the dawn of a new day where natural hormones just outpaced a weak insulin dose? Or are you looking at the aftermath of a desperate, invisible, midnight fight for survival? Truly understanding that difference is what transforms good care into life-saving care. Thank you so much for joining me in this explainer. Keep learning, keep questioning, and I will see you next time as we continue to break down the complexities of medical science one slide at a time.